Yeah, well, let's shift from
Yeah,
this,
sure.
because, like I said, it's a psychedelic podcast, and I loved how excited you seemed when I reaffirmed that. Um, let's let's talk a little bit about psychedelics, and because, okay, so specifically, I want to talk about MDMA and psilocybin, because I don't want to ask you as an IFS person to comment on unsubstantiated claims about other psychedelics. Although, if you'd like to, you
I can
could.
do that.
Sure. Okay.
I can do
Uh,
that.
but I was thinking first, at the very least, talking about MDMA for trauma, and then also psilocybin for, although it's not being used for
It
PTSD,
isn't. That's right.
I don't think, especially given the IFS framework, I don't think it's unfair to suggest that chronic or major depressive disorder or treatment resistant depression, which psilocybin is being used to treat, that this depression isn't actually a symptom of trauma. It's a complex bred of trauma, you know,
Yeah.
or smoking cessation. If addiction behaviors are parts taken to their extremes, I mean, smoking isn't necessarily an extreme, although it depends on your perspective. If a psilocybin experience leads one to stop smoking, well, they've obviously done some sort of IFS, possibly trauma healing. Same to be said for the tension around dying. Possibly this is a more like a metaphysical trauma of not being given like the deep rooted whatever structure of mind that allowed one to surrender onto, or surrender a whom to surrender onto, maybe in some sense, in the death process that they're undergoing, and that there could be a trauma healing happening there. But
Yeah.
specifically, but MDMA and psilocybin, I mean, from my personal experience, are extremely different. So,
Totally. Yeah, and ketamine. Don't forget ketamine in this category.
oh yeah, let's
Okay,
let's talk
so
ketamine too, actually.
let's talk. It's the three of them. From my perspective, it's the three.
Yeah.
Because I've done the CAP training, ketamine assisted psychotherapy training. Um, I have not yet done the MDMA training. Michael Mithover and I are friends, and we were supposed to be meeting at the end of May because Bessel was going to have his annual trauma conference and figure out a position for me within that world. And same thing with the psilocybin folks. You know, John Hopkins are really the people in the States that are doing a lot of the work. They just had a huge research grant. So there was a collective 1 day workshop at Bessel's trauma conference this year, and we're all going to kind of meet together and move forward in this way. So I'm involved in this world in a way because I'm involved in trauma, because I'm a psychiatrist, and I have some pretty strong views about it, both positively and negatively. And so I'm going to speak about it from the trauma perspective, I think, first, honestly, because
And can you, when you do so, I would appreciate if you could specifically talk about each of the three.
right,
I know there are general comments to be made about all of them, but
right.
I would love to hear your specific thoughts on each of the three as well.
Well, and that's the thing that, you had mentioned, and I totally agree. People, these drugs are very different. As a psychiatrist who did psychopharmacology, you just don't lump, psychedelics together because they're in a category that's similar because they're so structurally different. MDMA does very different things than ketamine does. There's very
Yeah,
different things than psilocybin does. So
yeah,
there is a part of me that's like, people don't lump them together. And this is part of why I want to have these experiences and really learn from this because ketamine does something very different as an anti-glutamate drug, for example, than MDMA does, which really accesses self-compassion and oxytocin levels and serotonin levels and norepinephrine levels. It really shoots people into self-compassion. Those are very different physiological experiences.
yeah,
Same
yeah.
thing with psilocybin and what it does with serotonergic receptors and things like this. So that you have to look at the structural differences between these meds and not lump them in the same category. And I do think there's a bit of lumping that's going on right now that I don't think is so great. Um, I feel that, and I'll also, because I know ketamine the most right now. There's such a difference between high dose and low dose ketamine. Okay, using the lozenges in low dose gives a very different experience. People are present, they're kind of aware, they're protectors from an IFS perspective, relax, and they can do some therapeutic healing work. When you start using IM or IV ketamine, you get shot into a transpirational experience and you are not present to do psychotherapy. Let me tell you, okay? It's a very different experience. So the drug has a therapeutic benefit and very differently if it's in high dose or low dose, okay? Um, and some people, for mostly in the States, IV ketamine infusions for depression. That's the way it became FDA approved here. That's not for trauma necessarily. Okay. We're starting to use, and I want to be part of this world of bringing psychotherapy into ketamine use. I have a dear friend and colleague, Elizabeth Call, who's been doing this work, and she's doing psychotherapy assisted ketamine work in low dose, where you do these 3-hour sessions. And we're talking about creating a curriculum, an IFS informed curriculum to help give people a framework so you do the healing trauma work while somebody's on low dose ketamine. And Libby Call, Elizabeth Libby, has been doing a lot of this work, but very few people are doing true assisted psychotherapy with ketamine yet. So that's in the works.
So I'm just going to pause there for a second.
Yeah.
Obviously, I assume there's no published research if there's just somebody doing the work and gathering case reports. But from their clinical practice so far, I know there's sometimes quite a divide between clinical practice and research.
Yes.
Is this physician or therapist noticing that the response is longer? Because generally it's looked at, okay, so someone comes in, they're given IV ketamine. They go from, I'm going to kill myself right now to, actually, life's all right. But it's like about 7 to 10 days if you're lucky. And then it's like, oh, wait, I want to kill myself again.
Yeah,
so
that's right.
Are they this doctor getting, I'm trying not to use gender pronouns because I don't know their gender. Yeah. Are they getting better results than the 7 to 10 day window?
Well, so I'll say this. So this is a woman, and it's Elizabeth Call, Libby Call. She's also one of the therapists in the MDMA study too. So she's in the phase 3 trial. She's very involved in this. She's she's not at Hopkins yet, doing the psilocybin work, but she's very invested, and we're dear friends, and we're collaborating on this together. She's done this longer and has more experience than I do in this way. There is this cumulative effect for all of these drugs, okay? So that you get ketamine response and then it fades away. So there's, you do these multiple sessions, which you do a medicine session, then you do processing. See, this is what we're learning about: process, do another session, process. So the time frame is not fully determined yet. That's with ketamine. MDMA, Michael Mithofer has a pretty good protocol now. You do a medicine session with MDMA, 6 to 8 hours, 2 therapists, and then you have several post-integrative sessions, psychotherapy sessions, and then you do a second, and then you do a third. So with MDMA, right now, there are 3 different sessions over a span of time. That's the protocol that they have. It's not clear for ketamine yet. Phil Wolfson is the guy that I did my training with. He's done a lot of the ketamine work. And he hasn't set up a psychotherapy protocol, but he really supports the process in the drug work. Okay. And it's new. This is a new, it's fun to be right at the cutting edge of something new in this way.
Totally, yeah.
To develop these protocols. And I feel like I'm one of the people that's somewhat well positioned to be able to do this with my history of working in trauma, with being a psychiatrist. So it's to be determined what a psilocybin protocol would look like with psychotherapy, okay, versus just drug treatment. So we're expanding all of these, and you can put cannabis in the same category because there are people doing cannabis-assisted psychotherapy. So it's really a new field. How do each one of these drugs work differently? What is the time frame? What kinds of therapy should be adjunctive to each medicine treatment is to be determined. Okay, so that's kind of exciting for me. And Dick Schwartz, the founder of IFS, is also very interested and involved in this. And we talked on the phone yesterday around starting to do some. He believes, and I do too. IFS is a great modality to help people process trauma when they're under any of the psychedelic experiences, but we've got to tease that out yet. We don't know. What Libby will say to me is, boy, ketamine really has protectors relax. And MDMA really shoots people into self-energy. You know what I mean? So this already starting to look at some of these differences. Not much experience yet because we don't have access up here yet to the psilocybin as much. The guy in Hopkins, that I don't know his name, but he's a really solid guy. I met him last year at Bessel's conference.
Is it Griffiths, Roland Griffiths, or maybe Charles Grobe? Those are the two major ones that I know historically, but I don't know who's actively working at Hopkins right now.
Are they at which I don't remember his name. I can't remember his name, but he's a really solid. I liked him. He knew what he was doing. Really reasonable guy, and I feel good about the work they're doing. We'll continue to collaborate with them in this way as this evolves. I'm going to say one other piece about it because this was one of the things that I'm very clear about, and I think this will be part of my role in this world, is the holding the line of therapeutic and abusive, because all of these drugs have abuse potential. I treated people who have done way too much of these in the party scene and have gotten psychotic and just not so good, burnt out serotonin systems. So as much as we've got to be mindful of the huge benefit therapeutically, we also have to be mindful of the abuse potential, because there is this culture that's like, oh, goody, we can get stoned legally now. Okay. And so I'm very mindful of the intent. Is this to have fun and party? Go do it. Is this for therapeutic benefit of healing trauma or depression or any mental health? Let's be very thoughtful about it. And one of the things, as you probably know, most of this stuff was legal once upon a time, and it went in the wrong direction in some ways, and then they shut it down. And I just think there's smart, thoughtful people this round, and I really hope it's going to be able to be therapeutically looked at. Like I really respect Michael Mithofer for the way they're doing the MDMA work. And I just think hopefully we're not going to go down that route again. And we're going to differentiate what's therapeutic and what's recreational and be able to make some big differences for people, because some brains really benefit from these medicines in a way that's so important. And I want to hold that piece so that people can really heal.
In having talked generally about, the different psychedelics, you had made these different assessments of each one in a way that seems very clear for anyone having listened to the whole episode. Like ketamine seems to soften protector parts. Well, now we all understand how that could be functional to an IFS session. MDMA shoots you into self-energy. Okay, great. Now we know what self-energy does, and in a good MDMA session, we could take that self-energy to all the places it needs to go in order to sort of like lay the foundation for effective trauma healing in the integrative sessions.
Exactly.
With psilocybin, I mean, you suggested that you don't have that experience yet.
Yeah.
Although it seems that the work from Imperial is suggesting that it's the pre-work and the post-work. The pre-work sets the person up, and then during the session, the medicine therapist is basically just there holding a supportive hand, literally or figuratively. And it's sort of like a series of IFS sessions leading up to it, although they have a different thing. They call it the accept, connect, embody process, which is not too dissimilar from IFS in some level, although it has a different modeling structure. Going in, you're finding wounded parts, you're bringing them up into the light of self-energy, if you were to use IFS to understand it. And then that works as the model that a person will sort of automatically lean into as they go through this psilocybin experience, which also includes possibly connecting with, love with a capital L, like the direct line to, the direct conduit, like plugs straight into source, like Neo at the end
Yeah.
of the third Matrix kind of thing. So, I mean, maybe less foreboding. That's a pretty foreboding image to put in people's mind.